of our program on pearls for taking up clinical exams for postgraduates easily. We have all teachers who are all MCI and DNB examiners. I hope in the next 90 minutes we will be taking home some good, at least 50 to 60 important points from the examination point of view. And the first talk will be by Professor K. Vasanta, who is my teacher, former director and superintendent of Renal Institute of Ophthalmology, and she will be talking on anterior segment case presentation. Next, Dr. V.R. Vijayaraghavan sir, who is also a teacher, will be talking on neuroophthalmology and orbit case presentations. Then it will be followed by Professor C.G. Vanilla, sorry about the spelling, from Institute of Ophthalmology, Joseph I. Hospital, Trichy, about uveitis, uvea case presentations. Dr. Nirmal Frederick, who is the director of Nirmal's Eye Hospital, Chennai, will be talking on refraction. And then I will be conducting a 20-minute missed call MCQ quiz. It's for the postgraduates. No big prizes, but the first, second, and third place owners will be getting a certificate to go with this. Okay. And the last presentation will be by Professor Rajmohan from Institute of Ophthalmology, Joseph I. Hospital. Now I invite Professor K. Vasanta Madam to come and give a talk on anterior segment case presentation.
Definitely be given as an examination case for you. So we'll start with the first case. This see, when you are presenting cases in the clinical exam, more than concentrating on the theory, you must tell whatever is reasonable treatment for that particular case. That way only we will be dealing with the clinical presentation cases. Not much of theory, but we want to know what you would do if this particular case comes to your clinic. So that is the way you have to go ahead in your presentations. Now if you see this case, you will easily say that this is a granular dystrophy because it's very typical. The individual small spots are there and spaces in between are clear. But this patient has got cataract. Now the examiner will want to know whether you will do only cataract surgery or deal with the dystrophy also. Now for this case, for this particular point, when you put the patient on the slit lamp, you must see whether the central part is clear. So if the central part was clear, the patient would have had reasonably good vision even through this pinhole effect itself. So if you remove the cataract alone also, he will be happy. Because as far as you can, you must postpone the keratoplasty as longer as you can. Because even in this particular case, what you will do is only lamellar keratoplasty. Even that, if you can postpone, it is better to postpone. Because when you are trying to do lamellar keratoplasty, there is a good chance that you may perforate the Descemet's membrane and you may have to do penetrating keratoplasty also. So if the examiner asks why you want to postpone even the lamellar keratoplasty, because the chances for rejection is less, even then you want to postpone. It is because if you can postpone, you have to do it because there is a chance for this case turning up as a penetrating keratoplasty. But if there were opacities in the center also, then you can say you will try for doing a lamellar keratoplasty and preferably cataract extraction also in the same case. And another question about DD will be about how to differentiate from macular dystrophy. This is a case where the patient had opacity already, and on that there is a small ulceration. You can see the small you can see the calcified spots. So this you have to mention. So whenever the calcified spots fall off, there will be ulceration in that area. So this is a case of atheromatous ulcer, because the calcified spots have fallen off and ulcer has occurred in that area. Because there is a good amount of congestion which shows that this is an active ulceration. So what you have to do in this case is treat this ulcer part, scrape off these calcified spots, and then epithelialization will usually occur over that and the ulcer will heal. And after that, what would you do? Now, you have to, in all these cases, whenever we give cases of leukoma to students, they will say they will go in for PKP. That is not the answer always, because in this case, you can see that the pupillary area is reasonably clear. So after healing this ulcer, what you have to do is find out what the vision is with this leukoma in place. Say the patient is having 624 or 618, you can leave the patient alone. And if the other eye is also normal, because most often if you do a keratoplasty when the other eye is normal, they usually are not happy because of high astigmatism and so many other things. The vision will not be that good, and chances for rejection, so many things are there. So as I told you, even now, as far as possible, if you can postpone keratoplasty, you have to postpone. So, and another thing is, this patient he has got pseudo exfoliation also. We will expect you to tell about that point and find out whether the patient has got glaucoma. And then you have to dilate this pupil and see whether the vision is improving with that. Then you can even leave the patient with a slightly dilated pupil. And in any case of adherent leukoma or oral leukoma which is slightly off center, how to assess the patient about whether the patient will get back vision with keratoplasty is to dilate the pupil and see how much of vision the patient is getting, because the patient may already be amblyopic. In our country, most often they come very late. So the patient may be already amblyopic, and after dilatation, if the patient is not at all improving, in that case there is no point in doing a keratoplasty. You may have to do it for cosmetic purposes. Those things are different. But you have to mention that you will dilate the pupil, find out how much the patient is improving, and then only think of other treatments. So this is all we have dealt with already. Like if you have a leukoma like this, what you have to see is dilate as much as possible and see whether the patient has got any other problems like cataract, because we have to plan for those things ahead. But in this case, will the keratoplasty have good result in this case? Yeah, tell me why you think the results will be good. Yes, see, there is no vascularization, there is a good amount of healthy cornea around, so the results will be good in this case. See, that is the thing we will be expecting. But if there seems to be, with this itself you can tell that there is probably adherent leukoma in this case. Compared to a plain leukoma, if there is adherent leukoma, the results are slightly less compared to a plain leukoma. So those are why we should look for adherence, is because the results are slightly less compared to a plain leukoma. So if they give a case of keratoplasty like this, what all you have to see is the type of suturing. In this case, there is a loose suture here. You have to mention this, because you will have to remove a loose suture, because that suture can attract vascularization, and vascularization can cause rejection later. So this is one point you have to see. And in case this was done for a case of macular dystrophy, you will be seeing some opacities here. So the cause for the keratoplasty also can be found out by looking at the case which is given to you. So those are the things you have to see. Then you have to tell that there is no evidence of any rejection, like no cavities, no flare cells. Those are the things they will expect. In all exams, corneal ulcers will definitely be kept. So you have to know the treatment which is given for fungal ulcer and bacterial, whether it's gram positive or gram negative. When you are giving 45 drops, all the concentrations which you must know, 50 milligrams in 1 ml for cephalosporin and 14 milligrams for tobramycin and gentamicin. And will you give amphotericin subconjunctivally? Can you give amphotericin subconjunctivally? Why not? It will cause scleral necrosis. See, all those side effects you must know, okay? And you must tell how you will put the drops, like fortify it by giving it frequently during the first 1 minute and then first half an hour, and then how to continue. So those are the usual questions that are asked. And see, this particular case is definitely a fungal ulcer. You can see the dry ulcer is a convex hypopian. So convex, relatively immobile hypopian, cheesy hypopian, and if there are satellite lesions and hyphate margins, those are the things they will expect you to see. But clinically, you can most often diagnose a case of fungal ulcer. So those are the things they will expect in the case of fungal ulcer. In the case of corneal ulcer, whether you are able to diagnose, differentiate between a fungal ulcer and a bacterial ulcer, and use these fortified drops, and those are the things they will expect. This slide they may not put for exam, but this is the type of case which are usually referred to cornea clinics. So I put this slide. Can anybody tell me what this is? You can see in these illustrations. If you see a case like this, you must immediately stain and see. You are seeing lot of yes? Corneal erosions, yes, correct. Corneal, why? What's the cause for this?
Welding, instead of welding, must use of welding machine.
Okay. Okay, that's, see, very often we get such a case. They will come with a box full of drops. They would have used, started using some drop for say conjunctivitis. It wouldn't have become better. They would have added some more drops and then steroids. So many things they would have used, and they will be coming like this to cornea clinic. What we have to do is just stock all the drops, give some artificial tears. They will improve. Okay, this is more for your clinical practice rather than for the exam. So because of the preservatives, you get this type of corneal erosion. So patients after welding and all that, they will come immediately. So for that also you have to give only artificial tears. But this particular case which I am telling is because of the preservatives in the drops. So besides in your orals, they will definitely ask about the investigations. So this, can you tell me what this one is? Yes, there are a lot. Timer will come. Just 24 seconds more. Okay, then I'll go first. So they will definitely slides or charts with topography, and then the doctor battery is low. Definitely be kept for you, because you have to know about specular microscope. See, if your case is in this particular case, you wouldn't even need specular microscope to see the cornea. With the specular reflection itself, they will ask you to demonstrate specular reflection. You have to keep the slit lamp at an angle, focus on the posterior most surface of the cornea to see the loss of endothelial cells. Okay, I'll just rush through the rest of the slides to show you. Okay. I'll just rush through. This is again an early case of fungal ulcer, and I'm sorry, the viral keratitis. Viral keratitis will be kept for you. This is a case of blood staining of cornea, another case which may be kept for you during the exam. So please learn more about the squamous cell carcinoma or intraepithelial epithelioma, because that case also will be kept for you in the exam if it comes. Thank you.
In a condensed form. But nothing wrong in repeating the same thing, because unless you keep on reading, anybody can answer. Reading once is very difficult. You can't, nobody can remember. So now we see, as far as neuro-ophthalmology is concerned, it's one of the easiest exam cases. You can always get through in the exams once you get a case of sixth nerve palsy, third nerve palsy. Common questions only they will ask you. Okay? Suppose a patient has come, most important is complaints and examination systems, examination patient. What are the complaints now? Go to. Probably we get about the complaints now, visual loss. See, if you ask a question of visual loss, you can yourself come to a conclusion. This is the most probable reason, etiology. I tell you, visual loss, sudden, patient comes to you. Think he is having an inflammatory problem, like optic neuritis, or an ischemic problem, sudden occlusion, whatever thing is there. If it's gradual, think he is having some toxic problem, like ethyl alcohol, consumption of ethyl alcohol. Okay? Or it's a compressive problem, any tumor compressing your visual system can be the gradual loss of vision. Whether you can come to a conclusion just by asking a question, is it gradual, is it sudden? Next you have to ask, is it unilateral, bilateral? Unilateral, think it's a case of optic neuritis, common. Whereas it's a bilateral visual problem, very rarely you can have bilateral optic neuritis. But most important, about the chiasma. Chiasma and above is a lesion. And another important question, you must always remember in young adults, think about David's disease. You know, we have got neuromyelitis optica. This patient will manifest as, please remember, sudden loss of vision in both eyes. In children, if you think, nothing wrong in telling the answer as optic neuritis. In children, bilateral optic neuritis is very, very common. Because after viral infections and all these things. That's why always ask sudden, gradual, unilateral, bilateral. Another thing is that when you ask the patient, he will tell you, yes, the visual loss gets deteriorated. After taking exercise or after increase the body temperature, everyone knows that is autopsy phenomena. Remember I told you on 5th, of course some of you might have attended, the reason for autopsy phenomena is some chemical changes or substances are getting liberated in the axonal areas. Are you follow? So that chemical environment is changing, that's why the conduction is delayed. If you tell that, that's enough for the answers. Another answer you can tell, because of increased body temperature, the demyelinating plaques becomes edematous and compressed optic nerve. The axons are compressed. Thereby more, the problem is increasing. So if you have answer, suppose you ask the exams, what are the causes for, what are the reasons for USOPs? You just tell these things. One, chemical environment, and two, compression by the demyelinating plaques. This is a common question you ask in examinations. Then, another problem, they will come to you, transient loss of vision. That patient will tell you. Not only visual loss, they will tell you transient loss of vision. Just ask questions. Transient loss of vision lasting for a few seconds goes in favor of papilledema, raised intracranial pressure. Transient loss lasting for minutes, you think it's a case of migraine. Now you have to ask a lady question about, are you getting scintillating scotomas? And you know what is tecopsia? Tecopsia, T-E-I-C-H-O. Tecopsia means scintillating scotomas. That means you have to ask a lady question, are you getting tecopsia? That is scintillating scotoma. If it is so, it's a case of migraine. That's a transient loss. Another common question we'll ask in exams, doctor, what are the common causes for transient loss of vision? Of course you know that, migraine, you know papilledema, but never forget about initial stages of angle closure glaucoma. Never forget that. Commonly we miss. Please remember, you can tell early stages of primary angle closure glaucoma patients can produce a transient loss of vision symptom. The common thing. Of course I told you, toxemia pregnancy, temporal arteritis. These are all various causes for transient loss of vision. Transient loss of vision may be toxemia pregnancy. Never forget that. It's a lady patient. You have to tell in the exams. Instead of temporal arteritis, ischemic optic neuropathy, All these things are supposed to produce a transient loss. Understand now? This is the way you have to answer the exams. Transient loss. Take care of it. See now. Next question I have to ask is pain. Pain, visual loss, movements problem. Movements, pain is increasing. It is optic neuritis. We know that. Pain increasing on movements with a visual loss. Painless, please remember. Of course, pain is there, unrelated to movement. Something like this, it is intracranial problems. Intracranial problems. Understand now? Pain is there, visual loss, movements, yes. Eye problem, optic neuritis. Pain is there, understand now? Visual loss is there. But please remember, unrelated to pain. It is mostly intracranial. Another thing is the double vision. Double vision is there, what's the point? Double vision is there, pain is there. You have to know something about painful ophthalmoplegias. Like Tola-Sagan syndrome. Never forget diabetes. Never forget diabetes as the cause for painful sudden loss of vision. So sorry, diplopia. Okay, and diplopia itself you can ask few questions. It is monocular, only one eye diplopia is there. It can never be a case of neuro-ophthalmology. Binocular, yes. Both eyes open, is having diplopia. It mostly is a case of neuro-ophthalmology problems. Then another way you can easily come to a conclusion, diplopia more on up and down. It is third palsy or a fourth palsy. Diplopia on horizontal positions more. It's a sixth palsy or internuclear ophthalmoplegias. Or to follow. Rather you can just ask a leading question, you can tell these are various problems. Of course they can have a history of flashes. Flashes on movements of the eye, it is vitreous. Flashes unrelated to movements, it is something occipital lobe problems. Sometimes you can have occipital lobe problems like in some of the irritation, all these things, they can have flashes. So always remember, flashes on movements, it is vitreous. It can never be a case of neuro-ophthalmology. Okay, then you see now, you are going to see the patient coming out. Okay, not moving. Good. Okay, now a patient comes to you, man. He is entering outpatient department. Just see the patient. Okay, whether he is having hemiplegia. Suppose gait is there, hemiplegic gait. Think he is having, please remember, suspect third palsy. He can have a Weber syndrome. You see the patient now, he is having tremors and all, he is coming inside. Think he is having third palsy, maybe Benedict syndromes. Please remember. Next. Okay. Then another thing is that patient is having a head posture. Chin elevated. Thing is having elevated palsy. Chin depressed. Depressor palsy. Turn. It's a horizontal problems. Tilt. Vertical muscle, particularly we have got obliques and recti, superior rectus and all these things. Always remember, one clue I told you. Suppose my right side superior oblique is palsy or right side superior rectus is palsy. The head tilt. What's the point? They are intortos, man. So head tilt will be towards sound side. Superior muscles paralyzed, named muscles are paralyzed, head tilt will be towards sound side. Inferior muscles are paralyzed, head tilt towards ipsilateral side. This is a clue. Superior rectus, sound side tilt. Superior oblique, sound side tilt. Inferior rectus, same side tilt, ipsilateral. That is the same clue. That way you can have a clue and see the patients. Then of course when you say a case of ptosis, you have to measure the ptosis, degree of ptosis, then you have to know about the L-phase actions, you must examine all those things, you must study the exams. Accordingly you have to tell the treatment has to be modified. Okay, depends upon the L-phase actions, depends upon the degree of ptosis you have to modify. So next you have to go Marcus gun. When you see a case of ptosis, always remember you have to look for Marcus gun. Here one classical clue is that if you see that lid crease line, please remember, if you have got a lid crease line this area, this lid crease line is there, think the patient will have Marcus gun. Lid crease line absent he may not have, because the lid crease line indicates what, man? It's an attachment of LPS. Attachment of LPS. Only when the muscle is well developed, naturally you can have a lid crease line. So when the muscle only developed, only you can have an elevation. That is why if you have a congenital, if you have got lid crease line is very nice, nicely seen, this case you are supposed to have Marcus gun. It's a classical thing we'll ask in examinations. Understand now? Okay. Next you of course I told you hemiplegic glades and all these things. Next, you see now, of course, you have to examine vision. Then gait, tremors, all these things are supposed to look for. Then I told you, when you examine the missing letters and all, hemiplegic patients can have problems. Sometimes crowding phenomena will be there in the case of amblyoppias. Later you have to see the patient when you take the visual acuities and all these things. Then I told you this. Okay. Then movements, most important. When you see the movements, pursuit, you know that, how to do the pursuit movements. Saccadic means you keep two fingers like this, ask him to do alternative look, or vertical saccades like this. Like this, understand now? Saccades, mainly initiated by your frontal lobe, exam question now. Saccades are commanding from where? Get command from where? Your answer is frontal lobe. Then for pursuit, where is the command coming from? Your answer is occipital parietal. Understand now? This is the common question we'll ask you. Front, saccades and all these things. Then you got, when you see the movements, never forget about the lids. See, when you move the lid can come close. When you move this side, lid may open. That is widening. Short, something narrowing up alveolar apertures you can see. Similarly, when you ask the patient to look down, you can have a lid black. That means what? You are going to see where is the case of thyroid, where is the case of what? Duane's. Always remember, when you examine the movements, never forget to see the lids as well as the alveolar aperture. See for any overactive methods, all these things. All these things are supposed to write down. Okay? Then see for Bell's phenomena, then all this. The reason you know why I'm having movement problem, man. But Bell's phenomena is present. That means you are dealing with a case of supranuclear palsies. Normally we don't give a case of supranuclear, but we'll ask you questions. How do you know it's supranuclear? The answer is, please remember, during movements of problem is there, but they will have dorsal movement is present. Then Bell's phenomena is present. That means it indicates it's supranuclear palsy. And one more thing is there, diplopia, please remember, is absent in a case of supranuclear. Diplopia never will be present in a case of supranuclear palsies. Only nuclear and infranuclear can have diplopias. A lot of common questions when examination will ask you. Of course, cover and cover test you are supposed to see. Now the pupil, you are supposed to see the reactions, size, shape, see for anisocoria. Now here common question is what? Anisocoria is there. How do you know it's physiological? You put a light, the pupil contracting. Suppose imagine now the difference in size is only 1 millimeter, man. Before reactions. Now I put a light, they are contracting, the difference again 1 millimeter. That means the difference is maintained in all reactions, it is physiological. Imagine now I am in third palsy. I put a light, people may not contract. That means what? Third palsy when I put a light, initial difference was 2. I put a light, now the third palsy people will not contract. Normal people contract. The difference will get aggravated. It's a pathological problems. So please remember in the exam questions, how do you know it's physiological? Your answer is, in reactions, if the difference is maintained, it is physiological. In reactions not maintained, it is pathological. That's all you are supposed to know. And then of course you should know the light reflex pathway, accommodation pathway, all these people's reactions, all these things. You must know something about the AIR people, something about AD's people. I'm sure now, all these things you are supposed to know. Because now and then, if you want to know, we can have a class 24 hours. Hello. We can have full day class so that you can understand neuro-ophthalmology very well. It's not difficult. One of the easiest subjects in the whole world is bloody what? Neuro-ophthalmology. Okay. Then I told you anisocoria. Okay. Then you know the RAPD, optic neuritis markers can people you are supposed to examine for that. Then finally, finally never forget to examine the fundus, man. Fundus, 600 palsy will have papilloma. Then diabetic changes are there. You can straight away come to a conclusion. This is a case of diabetes. Hypertension changes are. Hypertension is the reason. Then sometimes they will have an RP. RP, they can have Kenan-Sarre syndromes. You know that. RP patient can have a Kenan-Sarre mitochondrial inheritance problems. Whether you can see the fundus and come to a conclusion. Finally, when you tell them, you are supposed to take diplopia charting in the exam hall. Okay, exam hall you are supposed to do diplopia charting. I hope you know that. If you want to know, come, hello. You can, all of you are welcome to Coimbatore to Dr. Sanitai's clinic. Hello. We will come there, take a class for 2 days, don't worry. Okay, finally you tell which nerves are involved, site of lesion, what's the most probable etiology, people is bad or not, like that you are telling the exams. Then you tell about the diagnosis, and then you tell about investigations. Don't tell urine, all these things. You must take a diagnosis, MRI, straight away tell the diagnosis. Understand now? Don't tell, I will take a TC, DC and all. Something investigation to clean the problem. That's the most important thing. Understand now? This is the way how to answer the exams, and it's very, very easy to clear the exams. Very, very, one of the easiest subjects in the whole world is ophthalmology. Don't bother. Understand now? Thank you.
Fire session on neuro-ophthalmology. We'll return back to some sober session. No more scintillating pseudomas. You will see some light. And thank you, Dr. Chandrasekhar, for this opportunity. So on the day of clinical exam, most probably you will get refraction case as one of the last cases or last part of your examination. And if you have not done your clinical portion well, and this is literally a lead kindly light scenario, so you have to depend on the retinoscopy light to lead you out of the examinations. So the refraction case would be your hope and savior in this regard. But in the real world of practice, and it is your savior. So this is part of your syllabus. Refraction is part of your syllabus, since you need to know the basic knowledge of refraction as well as the fitting methodologies, lenses, and dispensing of glasses. So it's an integral part of an ophthalmologist's job, so you need to have a working knowledge about lenses, frames, and process of dispensing. So I'll just tell you some of the examination tricks. Retinoscopy is not very difficult. What you need to do is constant practice, because you are joining a elite club of ophthalmologists where retinoscopy and refraction, who have raised this thing to a visual art. And during examination, when you are doing this, keep your cool. It's very important you are calm and relaxed, otherwise you will not see anything, even if the light is very bright. So presenting a refraction case, the final diagnosis and exact treatment is easy, but the steps leading to diagnosing has to be mastered. So for this you need to practice, and practice. This is during your 2 or 3 years of post-graduation and not during the last year of your examination. It's very essential you take your daily work diary in case you don't get refraction or retinoscopy case on dot. This will really help you to convince the examiners. Look into the pages will enable your examiner to have a good impression of you. Some examiners allow history taking, some exams history of wearing glasses, power of present glasses and contact lenses will really help. History of systemic disorders, particularly diabetes, you need to mention. And family history should be listed in conditions like myopia and if they have squint. And symptoms like double vision, eye strain, headache really help in coming at a diagnosis. First of all, you need to know the visual demand of the patients, whatever profession they are in. All professionals have their unique needs. So in preliminary exam, you need to record the visual acuity, ocular motility and binocular function. And it's preferable you do this cover test, corneal reflex test, ocular motility and pupillary function. Even though you may not write in the case record, it's necessary you know this. And you need, if they are already wearing glasses, do a present glass check. So there will be some questions on retinoscopy. Why should you do it? Why is it important? And what all information you get out of retinoscopy? And how it is different from the autorefractor? And how you keep improving your technique as it goes on. But these are fundamental questions. You need to know the answers about this. There are basically 2 types of retinoscopy, static and dynamic. Static generally for routine refractions with the patient viewing at a distant target. So you are supposed to do the static retinoscopy. And when the patient focuses on a near target, and if you determine the accommodation and residual accommodation in a cycloplegia patient, then this dynamic retinoscopy. So one oft repeated question in exam is, what is the aim of retinoscopy and what is the the aim of retinoscopy is to find the lens that will stop the red reflex from moving. So basically the endpoint or point of reversal is the aim of retinoscopy. So when you view through the sight hole, you will see the red reflex, and these are certain things. The retinal reflex looks like a narrow band of red light that covers part of the pupil. If you have a trial lens, you will also see the light reflect on the rim. So ideally you should have a trial lens without rim or black coated rim so that it doesn't reflect. So this is with movement. So when you move, when the retinal red reflex moves in the same direction as the sweeping motion of your streak retinoscope, it is called as with movement. You can see in the lower picture. And against movement is when you move the retinoscope streak, the reflex moves in the opposite direction. So this is just to brush up your memory, and this is the point of neutralization. Is see there is no movement. So few tips on this. So what you have to focus during retinoscopy is the movement with or against, and then if the movement is with, add a positive lens or plus lens, and if the movement is against, add a minus lens. And you also should concentrate on see whether the reflex is bright or dull. If the reflex is dull, then start with the larger power. So if it is, you have to see the bright reflex. That means you are closer to the endpoint. So if it's bright, you can use a smaller power. So the movement, basically, this is what you are determining in retinoscopy. So movement of red reflex, no movement, against movement, and with movement. So now all these things have become easy in the practical practice area, that is with the advent of the automated refractors. You also you also have to know the difference between the retinoscopy results and AR results. You should also know about the pros and cons of this instrument. And then we come to the subjective verification. Ideal thing is to start with the duochrome. So the best sphere, what you give to the patient, is the maximum plus power, which gives the best possible visual acuity. Okay, so by increasing the plus power, you will see whether the vision is worse, or adding a minus power, you see whether vision is getting better. So if it's a presbyopic patient, you have to know about the approximate correction for near vision error. So this is the general rule, but it may vary from patient to patient, depends on the occupation as well as the general health of the patients. So then you have to write a prescription. So after you arrive at the retinoscopy results and know the near vision error, you have to write a prescription for that patient. And this is the accepted prescription model. You have to give power for the right eye, left eye, then spherical, cylindrical, then give the axis, and maybe in advanced refraction, they might ask you about the prism and how you give the prism. Then you have to give the reading addition if the patient is above 35 or require a reading glass. So generally, after all these things, many examiners are fond of this question, the cycloplegic refraction. So what are the indications and whom all do you do cycloplegic refractions? So all patients below the age of 12 or 10, you need to do cycloplegic refraction, and all cases of suspected accommodative spasm, and if there is a squint, and patient below the age of 30 years with a manifest hypermetropia, and if you feel there is a gross difference between this present power as well as the dynamic refraction, you need to do a cycloplegic refraction. And symptomatic patient who shows signs of astigmatism, you need to do cycloplegic refraction. And when you advocate post-mediatic test, this is one of the common repeated questions. Only when dynamic and static refraction show there is a difference of axis as well as power. And date again for PMT varies according to the cycloplegic or mediatic. This is a general time period. For atropine 2 weeks, cyclopin 48 hours, and tropicamide a day. And the olden day examiners are very fond of this transposition. After you give the prescription, and particularly if you want to give that in a minor cylinder form, you need to transpose. So these are the steps in transposition. The prescription for a lens can be written in plus cylinder form or a minor cylinder. minus cylinder is always better because it's easy for the dispensing optician to make it. And here this cylinder power stays the same. The cylinder sign changes. So suppose it's plus, it becomes minus. The cylinder axis again changes by 90 degree. And add the sphere power and the old cylindrical power to obtain the new sphere. So new sphere is a combination of old sphere power and the old cylindrical power. So then you have to give the full diagnosis so that will sum up your presenting the refraction case. You have to give them the prescription, and you also have to give advice on the single vision, bifocal or progressive requirement. So some of the examiners are fond of this practical elements in refraction, how you verify the spectacles, particularly if you are wearing a glass or the examiner is wearing glass, they will give you the glass and ask you to tell you the power. So this is a common thing that happens in the practical exam. So how you check the lens power, then you have to check the cylindrical axis. If there is a trial set, you can do this. Otherwise, you just have to judge the glass prescription by a simple inspection like this. So you have to move the glass back and forth to look for with power or against movement. Suppose it's with, it's a minus lens, it's against, it's a plus lens. If there is image magnification, it is a plus lens. If it's magnification, it's a minus lens. And you also have to look at the lower portion. Most of the examiners are quite old. They will have a presbyopic correction given. So you have to look for the magnification and peripheral distortion in the lower half of the glasses. So that indicates progressive bifocals. And you also need to learn about troubleshooting with glasses. What are the problems with glasses? What are the other options for corrections, particularly contact lens or LASIK? And surgical modalities of treatment. Suppose you have done very well in the clinical examination, they can go this far. The modalities of treatment, the laser corrections and the presbyopic corrections available. And they can also ask you about some preventive aspects. So that completes some of the questions and problems you face in presenting your refraction case. So refraction is a great scope, not only in exam, but all aspects of ophthalmic practice. So you need to concentrate on your retinoscopy and refraction practice to have a good ophthalmic practice here.
See, the uveitis is the main case here. You should be well versed in history taking. In history taking, you should ask for sudden onset or gradual or insidious onset. Whether it is acute or chronic, we will know from this, because all diagnoses you should write as whether it's acute or chronic. Then whether it's unilateral, bilateral, few etiologies are unilateral and few are bilateral. Then whether they are alternating. Then you should have a past ocular history, whether we have recurrences. So, and any relevant family history should be sought, and any disorders, systemic disorders, skin involvement, joint involvement is asked. For your, like any history of river bathing and all, you can have with iris granulomas. And any drug history, especially immunosuppressive drugs, if the patient is an HIV patient, heart therapy, or patient is a tuberculosis patient, ask for ATT, because those can manifest as uveitis. And accordingly, from the history, you can narrow down for a certain etiology and look for the clues. And for example, from the history itself, you can arrive at a diagnosis for readers if the patient has conjunctivitis, urethritis, polyarthritis. So, and it's said even from medical school, we learn whenever the exam should start, whenever the patient arrives to your OPD. So this will give clues to systemic disease, because most of the uveitis cases are related to systemic diseases. And like if you look for skin involvement, like if there are vitiligo patches, alopecia, you are thinking of a Watt-Bainagi-Harada syndrome. If there are oral ulcers, genital ulcers, then you think of vessels. So you should examine the patient as a whole.
And so this identification of anatomical site is very important so that you can classify whether it's an anterior, intermediate, posterior or a panuveitis. This will, you should tell that in your diagnosis. And response to the activity and prognosis you can know from and you look for secondary complications, not only what is in the history, but you should look in the examination for the secondary complications. It can be a band-shaped keratopathy, it can be a complicated cataract, even a thicical eye can be kept. The symptoms, all of you will be very familiar. In the examination, you look signs of circumcorneal congestion. In the exam, they usually ask how will you differentiate a circumcorneal congestion from a conjunctival congestion. That you should know. If there are in the conjunctiva, you should look for nodule. This is very evident in the case of sarcoid. And in cornea, it can be a keratouveitis or just endothelium which is studded with KP. So you should look for any evidence of varicose osteokeratitis or HSV keratitis. The endothelium, this is the favorite part of the exam questions. What are keratic precipitates? How will you know the etiology from the keratic precipitates? If they are fine keratic precipitates, it's an acute non-granulomatous variety. And if there are stellate capes studded throughout the endothelium, you are thinking of Fuchs uveitis. If they are pigmented, then it is a old or chronic uveitis. And if there are mutton fat capes, it's a granulomatous etiology and it's a chronic etiology. And frequently asked question is, why are the capes in the inferior aspect? That is the Alt's triangle. That will be because of the aqueous convention current. This you should know. And the AC, you should look for the reaction. You should look for the cells and the flare. If there are cells, it is denoting an active acute uveitis, and flare is because of the breakdown of the blood aqueous barrier. And you should also look for inflammatory signs like hypopyon, fibrinous exudates, and hyphema itself can be there. This is to show you the flare. The phenomenon here is physical phenomenon which occurs is the Tyndall effect. When light enters through a beam, the Tyndall effect makes the cells visible. And the millimeter of the slit used for this demonstration will be 3x1 millimeter slit, and maximum illumination should be used. This shows the whole AC is full of cells. And this diagram shows the mutton fat capes, and so you will think of a granulomatous uveitis. This have both crenated and pigmented capes, so it's a old chronic uveitis. The figure on the inferior is studded with all throughout the endothelium, so it's a Fuchs uveitis. This is an acute uveitis where you have the fibrinous exudates with hypopyon, so you will be thinking of an acute anterior uveitis. The iris, you should also look for signs of posterior synechiae. The synechiae can lead to festoon pupil. And if it is total, it is called the annular synechiae or the ring synechiae. It's also called as seclusia pupillae. If there is peripheral anterior synechiae, which can lead to secondary glaucoma, it is very important to check for this sign. Then there can be nodules on the iris. It can be Kopis nodules, Busakas nodules. This is one of the favorite exam questions. And the iris color. Iris heterochromia should be sought. The difference between the one eye from the other eye, that is usually seen in Fuchs uveitis. There can be iris atrophy. It can be sectoral or generalized. This is usually seen in herpetic keratouveitis. And neovascles of the iris also can be seen in chronic uveitis. So these are the pictures showing the festoon pupil. The inferior one showing festooning with the cataract. This picture on the top shows all total ring synechiae with occlusion of the pupil shown inferiorly with hypopyon. So whichever is there, with the classical appearance, you should definitely describe from each of the findings. This is also, there is our iris nodules throughout, studded throughout, and in the inferior one it is almost total with the leukocoria. There is occlusion, iris nodules in the case of chronic uveitis. This is a single iris granuloma which is seen down in the, it is iris slightly, there's a circumcorneal congestion, so you will think of an infective uveitis. And this, there is iris nodules in the pupillary border, and then this patient had, this is a granulomatous uveitis, so it is almost white eye, so you should think of granulomatous disease. This patient had syphilis. Syphilis you should not forget as a granulomatous, cause of granulomatous uveitis. This is a case where you can see the iris atrophy. This is the old case of herpetic keratouveitis. This is a case of retinal vasculitis who have also a new vessel formation elsewhere and with the neovascularization of iris. And in all cases of any uveitis case, you should never forget to do a gonioscopy because there can be a peripheral anterior synecdoche or a neovascularization at the angle also, and even at the hypopion can be seen in the angle. And the lens, you should look for evidence of complicated cataract. Now you will be asked what are the signs, how you can tell this is a complicated cataract. There is a triad of rectum appearance in the posterior subcapsular region with a polychromatic luster. This is all the three if are evident, then it is most probably a complicated cataract. With other signs of old uveitis will be there. This is the sequelae of chronic iridocyclitis, where you have a band-shaped keratopathy. That's a secondary complication that has occurred. There is occlusio pupillae, seclusio pupillae, and complicated cataract. If you look for diopy, it will be little reduced. So it's either pre-thicical eye or thicical. And if you go in the posterior uveitis case, you should look for vitreous. In the anterior vitreous, you should look for, even in the slit, when you are doing the slit lamp examination, you should look for the vitreous Flahren cells. Same thing how you are grading the anterior chamber Flahren cells, you should grade the vitreous flare and look for whether it is, if it is an inflammatory pathology, you will have most probably the WBC. So you will have vitritis. If it is located only in the inferior vitreous, then your etiology will be a pars planitis. If it is more bigger granulomatous like snowball opacities like you are seeing the vitreous, you are thinking of granulomatous etiology just as sarcoid or candidiasis. And sometimes because of retinal vasculitis there can be a vitreous hemorrhage because of the NDEs. This is a pars planitis and snow banking. And in a posterior uveitis you should also examine the retina and choroid. So you should do systematic evaluation, like where the location of uveitis is there. So if you locate, then you can come to an etiological diagnosis. If it is involving the posterior pole, it will be like an acute multifocal pigment epitheliopathy. If it is involving the posterior pole and the peripapillary region, it is most probably a serpiginous choroidopathy. If it is mostly involving the periphery, plus or minus the posterior pole, it is acute retinal necrosis. And in the case of toxoplasma, usually you have a lesion very close to a heel pigment. And the retinal vessels, you look for sheathing of the vessels and arteriolar narrowing. This is a case where you have a lesion very close to the pigment. So this is a case of toxoplasmosis. This is the most common cause of posterior uveitis. This is a case where you have a serpiginous heel lesions as well as active lesions. It is in the peripapillary region and the posterior pole, so it is a serpiginous choroidopathy. In this, you have a disc edema, you have all the brush fire appearance showing the CMV retinitis. Inferiorly, you have the retinal vascular sheathing, so active retinal vasculitis. And this is a case of posterior uveitis. You can see a subretinal lesion just inferior to the fovea. You should describe how much diameter the lesion is and with fluid. So this is a case of choroidal granuloma. And this is a case where you have active retinal vasculitis with hemorrhages with macular edema showing the macular star appearance. This you have conjunctiva involvement, so nodules are there, then you have retinal vascular sheathing and a snowball type of opacities, that is the Landers sign. So all three together in the same patient you are thinking about a sarcoidosis. So from your examination you should also examine from the anterior segment to the posterior segment. This is a case where you have exudative retinal detachment is there, disc edema is there, and you find a big light like with the scolex. This is a intravitreal cysticercosis. So in the optic nerve you should look for optic disc edema, neuroretinitis signs, and a glaucomatous cupping. Because you are on and off using a steroid, it can be a steroid responder, so you should be always looking for a glaucomatous cupping. And then after you are finished your examination, you can come to a classification. You classify whether it is anatomical, clinical, etiological or pathological. So this is a standardized EVN nomenclature. All of you will know this, whether it's anterior, intermediate, posterior or pan-uveitis. And it also is, first you should tell the anatomical side, next you should tell whether it's a chronic, limited, persistent or recurrent uveitis. You should keep on adding adjectives to your diagnosis and probable etiology, whether it's endogenous uveitis or an exogenous uveitis. And the International Uveitis Society groups have classified this uveitis as all in from your textbooks. And pathological diagnosis, whether it's a granulomatous or non-granulomatous. Usually this is asked very commonly in the exams, whether it's a granulomatous or how will you differentiate. So whether it's an insidious, chronic course, mutton fat, KPs are there, nodules are there, less symptomatic usually goes for chronic. Then intraocular pressure measurement is very important in uveitis. It is active uveitis, it is usually decreased. Sometimes in chronic iridocyclis, the eye is going for crisis, it's decreased. And it can be increased due to various etiology. It can be an open angle glaucoma because of blockage of trabecular meshwork. Also associated trabeculitis will be there, or the posterior block is there. It can be an ankle closure glaucoma where there is a peripheral anterior synecdoche or the ciliate body swelling. There can be a steroid induced glaucoma. I can just take 1 minute more. And you should do the investigations. It can be a lab test, FFA, ICG, OCT, D-scan, UVM, AC tap and vitreous biopsy, and these investigations will continue to help you in your management. Thank you.
Going to be a missed call quiz. Now you just see if you have your towers on your mobile phones. Do you have your towers? There's one more talk after this. It will give us some time to calculate the marks. Okay. You have your towers? Okay. Now this quiz was conducted last time in Hyderabad for the first time in the world as a missed call quiz. I'd like to thank Mr. Sai Krishna and his team. And Sun Pharmaceuticals was responsible for sponsoring this program. It is quite expensive. There is no cost on you for calling us. Previously we used to have SMS quiz which would cost you anywhere between 1 to 3 rupees per call. Now, kindly listen to what I am telling properly. You can save these numbers as AA, AB, AC or something like that in your phone. These numbers are the numbers to which you have to call. Okay? For answer A, supposing your choice is A, you have to call. This is just like the missed call which is being done general by Dr. Paresh Miskati. So you have to ring. If your choice is A, you have to ring 80672 64601. Correct? Huh?
Yeah.
And if it is choice B, you will have 3 choices for each question. No negative marks, but you have to do it within a period of 30 seconds. from the time we put the slide, you will have 30 seconds to call. Once you get the call, it will go for a ring.
To go for ring and it will get disconnected.
Automatically it will get disconnected. You don't disconnect. Don't be frightened that once it gets connected you will lose the money. So you have to wait for it. Automatically it will get disconnected. There is no problem. Only make sure you make the correct. Actually I will give you a trial question. You can make a call and see whether it's correct. 806, but you have to put necessarily the plus 91. There need not be a gap. No gap. I'm just for discrimination I put this gap. Plus 91 806726 46, not 1. And again 2, 3 for the B and C. Okay, are we done? You, no, okay. Because if you save it as A, B, AC, you can easily recollect it from your contact list. You don't have to search. Once you're done, you tell me, we'll go to the next. The pages will open once the slide comes on board. It will wait for 30 seconds. Next will be a blank slide. Once you get the blank slide, it will be closed. After that, whatever you ring will not be taken into account. Am I clear?